Well, hi, everybody. It's good to have you with us. It is February 5th, huh? February 5th, 2021, for those who are looking at this, 2031. I think some of the things we're going to talk about today are things that may be useful to you 10 years from now, because some of the things I'm talking about are things that you learned in dental school. I know there are a lot of periodontists who are watching this. There's some prosthodontists too, and some general dentists. And so the prosthodontists and general dentists are going to look at me and they're going to say, "What? You don't know that?" And others are going to say, "Oh, I didn't realize we need to apply these principles, these dental principles, in order to avoid dental implant nightmares," which is what we talked. So uh, that's the title. Change the title a little bit, because actually I was going to present two cases, but there's no way on earth I can present two cases to you today. There's too much from the first case, or at least what I chose to be the first case. It's actually the second case that we're looking at today. Someday we'll do the first case as we accumulate reasons to do that. But this is going to maybe tax you a little bit. You may say, I don't need to know that. And I'm going to tell you that if you're going to be a director of dentistry, if you're going to be the person that a patient relies on, you'll see this in a second. If you're going to be that person, you got to know this. You got to know this. You got to have that tool. And the tool is something that you learned at one time, as I said. And, as I said, you may not have that now, but you're going to get it back. And you're going to get it back as a result of today's session. So you'll want today's session. You'll want this, because it will mean patients have more confidence in you. That's how much of a difference this will make. So unless there are any questions to start, and I don't see any, let's get going. Okay, so today's a full denture case. We're going to talk about the full denture case, yeah. And how do we get this to go full screen? There we go. Okay, good. All right, so the full denture case, become the diagnostic resource for the patient, which essentially means become the director of dentistry. And the director of dentistry is the one who runs the case. You get a misimpression when I say you run the case. It doesn't mean you run the case and the other person doesn't run the case. It means you acquire enough knowledge so you can run the case, so you can diagnose and treatment plan the case all by yourself. And that's what you want to be able to do. That's what you want to be able to do. Why? Because you want to be the resource to the patient. That means the other person, the other guy, the other gal can be the resource to the patient too, but we don't want to put ourselves into a secondary position. We want to be in a primary condition to be able to speak with our colleagues and speak with the patient on an even plane, not on this kind of a plane, not on this kind of a level where prescription surgery is going to you, you do what you're told to do, and it goes back to the other person. That may work sometimes. Maybe working for a lot of you, maybe working for a lot of people. But if we're looking for the ability to be a resource for the patient, then we've got to be able to put ourselves in the decision-making capacity too. And then, of course, we talk about how we get patients interested in us and all that type of thing. And you're going to see a patient today who is interested in us for full dentures. Yeah, she knows I do implants. Yeah, she did. She did. So let's take a look at it. Okay, we first thank Allison at the Oral Reconstruction Foundation for providing us with continuing education units every week. And for those who are on live, you get your continuing education credit for this. And to invite others to this treatment planning series, just go to directorofdentistry.com and click on this link to sign up for the free material. Hang on, let me get my annotation device here. Yeah. So sign up here, sign up for the free material, which is now being blocked by a screen. Okay. Click on that. You'll get on the list and you get those materials. Okay. Oh, what happens when I use the drawing thing? That's all right. I got it. I can't do that. How do you like that? All right. forgive me while I work with this for a second. Okay. Okay, so the intake call, notice when the intake call came in. It came in Wednesday, February 12th, 2020, almost 1 year ago today. Okay, came to our front desk, Danielle, and she said, and the patient said, I'm interested in implants, and the patient was scheduled on Wednesday, February 26th. That's 2020, a year ago. Okay, 3 p.m. Okay, my son, Matthew, made the doctor call. She has temporary dentures. It was done with a corporate dental office. She's paid for finals, but hasn't received them yet. She can't wear the lower. She's interested in lower locators. The lower denture she gets from corporate fits okay. She wants to reschedule her appointment with us after she gets her final denture. So she already decided during the doctor phone call that she wants to discontinue the patient, or she wants to cancel the examination. Now, that's interesting because she hadn't called us to say that. So the doctor call essentially gave us the opportunity of having that open space rather than the patient saying, well, okay, I can cancel on the same day, because a lot of people have that impression they can cancel on the same day. Well, you know what it's like. So doctor phone call essentially elicited some information, plus the patient receives a call from a doctor. What could be wrong about that? Okay, so let's go forward a little bit. Okay, so now she calls again on January 26th. So she called, what, 10 days ago? Something like that. Okay, she called Jennifer, says to Jennifer, she's ready to find out her options for snap dentures and scheduled before COVID. Okay, so she comes in and she sees Laura. Laura's been with me for 15 years, okay? And her needs and wants is she had upper and lower teeth extract in October 2019. She has permanent dentures. She says the dentures are too thick and the bottoms will not stay in. She feels that the teeth are too big or there are too many of them. Patient has been shopping around. And by the way, when Laura came to me, she said the patient's been shopping around. How do you like shoppers? I don't know. How do you like shoppers? Frankly, I like shoppers because I know that I can impress them to the point where many of them will stop shopping. That's what I'm teaching you today. You know, we don't like shoppers. They're going to go look for the best price. And she was looking for the best price. She was. I don't have the best price. You already knew that. All right. So understand that what a patient says, particularly with regard to cost, may not make as much of a difference as what I'm about to show you right now. Okay. So let's continue. Okay. She talks on the phone for a living, and she takes out her lower dentures so she can talk. The patient says when she talks on the phone, hang on, click, yeah, okay. And sees S's and F's and 6, and the number 6 is hardest to speak. She said she whistles a lot too. Okay. Is that important to somebody who talks on the phone for a living? I think so. Okay. So what do we know already? We know that she's had her dentures for a year, that she's gone shopping to multiple dental offices. That's what she told Laura, and Laura told me that in the doctor briefing before I went down to talk to her. I'm upstairs and we do our examinations downstairs. I have my private office up here. That's where I'm doing this thing from right now. Okay, we know she talks on the phone for a living. She can't pronounce some sounds. She can't keep her dentures in both upper and lower. What else do we know about this patient? Why didn't she stop at one of those other offices that she went to? It could be price. But maybe the needs were never addressed. Maybe she wasn't convinced she was going to the right doctor. Possible? Think so? Yeah, it could be. And that's why the diagnostic appointment is not just for information. Data is very, very important. But it's not just data. It's showing the patient that you care. Might have been showing the patient you know something. Okay, very easy to walk into corporate dental, and corporate dental 10 minutes with the doctor, and there's only one thing that's being done. I'm talking about corporate implant dental, okay, or any implant dental, which is where all they do. Okay, we're going to put implants in, we're going to put in fixed zirconia prosthesis, you're going to be all done, it's going to cost blah, blah, blah. That's the end of it. Then they go to the assistant, and the assistant will close the case. Close ratio on some of these corporate entities, and it's only, I haven't studied it myself, I'm only getting it from somebody else, it's around 10%, maybe as high as 25%. I can't work on that kind of a close ratio. That doesn't make any sense. Not with the amount of time. Patients in our office for 2 hours. I spend a half an hour with the patient. Sometimes I spend more on complex cases. Yeah, I mean, so we're not looking at, all right, this is what we do here. This is the only thing we do. Everybody's the same. We don't look at that, even though I do that kind of treatment. We do a lot. In fact, it's being done downstairs. Dr. Furtado is doing downstairs right now as we're speaking. Okay, so understand that it isn't just that. And if you're trying to compete on price and say, well, I can do it cheaper than blah, 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 that's frankly a losing game. It is. It is. Okay, there's a certain value associated with price, and that's what we're going to talk about more about today. Okay, so she's gone shopping. She talks on the phone for a living. She can't pronounce some sounds. She can't keep her dentures in, both her upper and lower. That's what we know. What should we do? We should address the fact that she talks on the phone for a living, that she can't pronounce some sounds, and she can't keep her dentures in, both upper and lower. And we ought to do them in that order because that's the order that she decided is most important. She talks on the phone for a living. And remember, she can't pronounce C's and 6 very well. So that's what we do. Concentrate on the areas that are bothering her the most in the diagnostic session. So here she is. Nope. Let me go back. Sorry. All right. So here she is. So what do I do with her? I ask her to pronounce 6. And she shows me what happens. And she tells me that her back teeth are coming together and that she whistles a lot. And she says 6, and then I say, well, let me try a couple of other things. Let's do an F and a V, because at least I can get the idea of the relationship of the upper teeth to the lower lip and see how she's doing with that. And her teeth click together. But what you tell us in the diagnostics, in the session where we're getting some information, she told us she takes her lower denture out to talk. So what should I do? What should you do? Take out the lower denture, of course. All right, now talk. Okay, she talks. She pronounces her S. She pronounces, and we go to the Mississippi and we do 66 and all those types of things. And she said it feels better. And my teeth don't clack together. And that's why I keep my lower denture out. Besides that, I whistle less when I have my lower denture out. Does that mean something to you? Sure means something to me. So we look at the sounds and we say, what do we need to do in order to be able to make things better? Okay, then I have her look at the upper denture. Say, all right, how do you like the upper denture? How do you like the upper teeth? So the upper teeth look pretty good. Okay. So she likes the upper teeth. By the way, she doesn't like the lower teeth. She tells me the lower teeth are too long. Lower teeth are too long. That's not the way her lower teeth looked. Sarah, that's interesting. We'll take a look at that in a moment. I want to make sure that we've gotten every speaking sound taken care of. Are there any other words that you say that where you're just not able to pronounce them well? And she might give me a few. What's the importance of that? I keep on asking her for information so she can give me more information. I'm coming to no conclusions. I'm only asking questions. Okay, what are some of the things you say in your job? And she might give me some of the words that she says. I said, thank you. Good, I understand that. I've got it. I appreciate you telling me that. Okay, let's move on. So let's take a look at the CT scan for a moment, just so you can get that. And by the way, take a look at the maxilla of the mandible, and you'll take a look. If we look right here, okay, right here, you've got maxilla is good. Everybody recognizes this right here, right? You recognize there's a cyst in the sinus. Does that bother you? It doesn't bother me. I suppose it should. Maybe it should. I think we see enough of those. They're isolated. There's, could be a big polyp, whatever it's called. We're not going to go crazy over that. If I were doing a sinus lift, I may, but we're not going to do a sinus lift here, are we? You can do a sinus lift here. Let's take a look at the bone. So we'll go across the maxilla. And you'll see the sinus is prominent on the right side, upper right side. We go to the anterior. Take a look at that bone. You like that bone? I like that bone. We'll measure the bone. And I'll take a measurement in the same place where the vertical crosshairs are, just so I can kind of calibrate myself. I can see, all right, that's what, 16.91 millimeters. So I kind of know where I am. A lot of good bone there, okay. No way on earth, by the way, if we did the maxillary prosthesis or we did maxillary implants, that'd be in those sinuses at all. We're going to place angled implants around those sinuses. Don't touch the sinuses. Don't tell me, oh, sinus lifts are easy and they're so predictable. There's a little bit of baloney that comes across from surgeons, maybe including me. Don't touch a sinus. I mean, most sinuses do fine. When a sinus goes bad, it's really bad. And we don't need to use it. Don't do it. Just stay away from it. It costs too much money. There's too much risk. And there's plenty of bone here to place an angled implant. Just don't even think about it. You don't need it. Okay? Fixed case, we'll talk about that, where the patient has anterior teeth. But right now, take a look at how much mandibular bone she has. What does that say? 28.51 millimeters or something? What is on that one? All right, 29 millimeters. Okay, so 29 millimeters of bone. Is that a big mandible? I'll correlate with that with what you saw on the lower teeth. How long were those lower teeth? Okay, I'm giving you a hint. You'll find it. There's more. Okay, let's move on to the next. Okay. So now let the patient work with their chief complaints and show you, and that's what we did. And I'll get rid of those annotation marks. Okay, good. So we did the speaking sounds, SF and V, and then work with the upper, because she said the upper doesn't stay in either. I didn't tell you that. The upper doesn't stay in either. She has to use adhesive, and the adhesive doesn't work very well. I said, do you like the way the upper looks? Yeah, I like the way the upper looks. It's fine. Okay. And she did fine with her F's and V's. Okay. This is not precise, but it just gives you an idea that she's okay with the way the upper teeth are. She likes the F's and V's. She likes that. You could all criticize the smile line. If you take a look at the contour of the lower lip, that's supposed to duplicate the smile line, the incisal edges and the buccal cusps of the upper teeth. It doesn't. It's flatter than the lower lip. Okay, it is. So what? The patient's happy. I want to concentrate on what the patient's happy with. She's happy with the looks of the upper denture. But the upper doesn't fit very well, and that's a problem. And I go in the mouth, and it's loose. There's no suction there. And I take a look at the borders, and the borders are short of the vestibule. So what do? I take some rope wax. I love rope wax. If you don't have rope wax, get rope wax. Periodontists, get rope wax. And so I start to border mold using rope wax. Okay, I know any prosthetist looking at this and saying, what the heck is he talking about? It must be a periodontist. Yeah. So I used the rope wax and I increased the height of the flange so that it goes into the mucolabial fold. And then I put it back in, and guess what happens? It's better. So, gee, we've done that well. Let's go a little bit farther. Let's place something up in the tuberosity, because in the tuberosity, that's usually where we're short. Border molding is usually good in the anterior. It's often lousy. We don't capture the posterior. So let's build that up too and put it back in the mouth. And I did. And she said, that's better. I said, what, about 10%, 25% better? She said, no, it's 50% better. I did that with rope wax. And by the way, the next step is to put a posterior palatal seal with rope wax, which I'm not showing you here. And it didn't improve it at all. Okay, so we know it's the border molding. The posterior palatal seal was fine. Okay, so we know we're in good shape. I know that if she's 50% better and she's already satisfied, that there's a good chance I can do a co-soft reline in the upper. Let me get out of here for a second so I can talk to you. I can do a co-soft reline in the upper. Make sure the co-soft goes over the borders when you take it. And make sure you don't, when you're doing your co-soft, make sure you put a minimal amount in the area of the premaxilla. Okay, otherwise you'll shove the thing forward. So you're trying to get border molded, and you are increasing the amount of material, but not very much. And if you're going to do this right, if the denture is thick enough, you actually relieve the denture. Okay, now you may not want to do it in a case like this because you're not sure, may not want to destroy a denture where the patient says, I'm okay. But if you're taking a final impression or final reline impression, you're doing co-stop, she's already agreed to a reline and knows that there's going to be a little bit of a risk in a reline. It may not be good enough. We might have to go to implants. Then yeah, I'll ream out the denture. Of course I will. We don't ream it out so it's so thin that it loses integrity, but we take a lot of material out because the co-soft is going to replace the material that's been lost. We don't necessarily want to make a thicker denture. And so we've got to relieve it in order to be able to allow the co-soft to do its work. Co-soft's pretty viscous. Then we put it back in the mouth. We have the patient bite down. We'll actually border mold it ourselves, do this with the cheeks, whatever you like to do, and let the patient, and then take it out, and then we'll trim it. Okay? I didn't do that at this visit. This is just a diagnostic visit. Diagnostic visit of saying, listen, I know I can get it better with rope wax. I think we can do pretty well with a reline here before we spend the money on dental implants. What's a reline going to cost? $400, $500, $600? What's dental implants going to cost? $15,000, $20,000, $25,000, whatever it's going to cost. All right. Am I working with her? Yeah. Yeah. And she's getting that impression. Oh, here's a doctor who did something that the other offices didn't do. I'm not talking to her about implants. She may not need implants. I know she doesn't have very much money. She wouldn't be shopping around. And I'm not going to do any more treatment than the patient needs. The patient's already happy with the upper denture, and she's smiling now. And she's feeling pretty good about this and feeling pretty good about me and where she is. That's what we want to do with the diagnostic visit. And if we're doing something that's different from what the other dentist did, do you think she's going to keep on shopping? Do you think she's going to be as price sensitive anymore? You know the answer to the question. Okay, let's get back to this. Okay, so now we've assessed the upper, now let's assess the lower, okay? And I want to make sure you can see everything. Let me make sure on this share screen. Yeah, we got it. Okay, good. We'll take a look at that lower. Do you think that lower looks right? What looks weird about it? Well, he's showing an awful lot of lower gingiva, acrylic. Does that look right to you? Okay, let's take a look at some principles here. So this comes from a plastic surgeon in Singapore. I just took it off the internet. Okay, it talks about the third, and the third idea of how a face is divided up. Now, we're not all a third, and a third. Some of us are a lot more beautiful than others of us. But here's some basic principles we can look at. So from the hairline on the upper to just below the eyebrow, that's 1/3, down to just below the nose, where the nose and philtrum is, that's the next third, and then the chin is the third. And then you can divide the upper lip and the lower lip by 1/3 and 2/3 if you want. And you can, not if you want, but at least this gives you an idea as to what the desired proportions are. Let's take a look at her proportions. So take a look at the hairline to just above the eyes, just below the eyebrows, and look at the distance there. And hang on, let me do some annotations here, which screws everything up, but what the heck. I'm going to have to learn how to work this. I thought it was pretty good. So let's go back. Okay, so now we take a look, and I know you can't see my my mouse, but I just found another way of working this. So yeah, let me try the mouse again. Some things, sorry, I'm flubbing around a little bit. All right, so now we take a look at this distance from here to here and compare that to this distance from here to here. And compare that from this distance from here. Come on, mouse, you can do it. Yeah. Okay. Now, is that a third and a third and a third? No. And if you take a look at the distance between where the nose and the philtrum joins and the chin, that's a pretty big third, which can be controlled by what? The vertical dimension of the denture. So this gives me a hint. Number one, her teeth clack. Number two, it gives me a hint that she isn't following the proportion by any means, particularly from the nose to the chin, which is arbitrary and which we can control. That's something that I may want to spend a little bit of time on. Okay, I'm going to show you some material from Sandy Halpern's book, and this book was written in the 1980s, by the way. Mastering the Art of Complete Dentures, which gives us some guidelines to look at. So let's take a look at that. All right, McGrane took, like in the 40s, I think 46, 48. I talked with Sandy yesterday. He measured successful dentures. That's what he did. He took a caliper, measured it from the canine area, from the extent of the flange on the upper and the lower and the canine area, and he saw there was a constant. The constant was 40 millimeters. Okay, when you measure from the canine area, the upper canine area, the lower, you measure from flange to flange. That's 40 millimeters on the successful denture cases. Okay, and he measured hundreds of dentures according to Sandy. So let's take a look and see more about this. Okay, we can subdivide that 40 millimeters into 22 millimeters from the edge of the canine to the flange, and 18 millimeters from the edge of the lower canine to the flange. Okay, so the upper is 22, the lower is 18. Are they always exact? No, of course not. But it's a guideline that we can use. So now let's take a look at her and take a look at the ridge, which I'm sure you know, good keratinized ridge. I mean, surgeons would love to work on this ridge, wouldn't you? Would you like to work on the ridge this way? Let's find out. Okay, remember the dot in the nose, dot in the chin? Okay, we used to put it directly on the nose, directly on the chin. Now little bit kinder, we put some tape on there, and we put a dot in the nose, dot in the chin. With the dentures in place, have the patient close down, and we start to use our tongue depressors, and we draw our pencil line. Put your pencil line in any place on the upper. You only have to draw one pencil line. You know, match the upper pencil line to the upper dot, and all you have to do is draw the lower pencil line when you're against the face. Okay, so we do that. And sorry, it's a little bit messy. Okay. And now we have the patient take the denture out, and we say, all right, let your mouth just come to rest. You know, lips together, mouth come at rest. Let your mouth come into a comfortable position. And now look at where that pencil line is. Okay, teeth in place is opening her mouth farther than it should. She's much more comfortable in that position. What do they call that? Prosthodontist, we call it. Is that the repose position? Or is that for somebody who's dead? I forgot. But I'm a periodontist. What can I say? And so we measure that with a periodontal probe, which is the only measuring device we have to use, of course. We don't use calipers or anything like that. We use periodontal probes for everything. And I use a periodontal probe for everything. Okay, so I measure it. It's a 7mm discrepancy between her occlusal position with the dentures in place and with her position with the lower denture out. Okay. How much distance do you need for freeway space? 2mm. Okay, that's a rule, 2mm. So she's really open 9mm. That's something? 9mm. Okay. So I already know there's a problem with vertical dimension, and now so do you. Now, I also want to know what the denture itself is like, because I want to know if the denture, if we were in a normal condition, which we're not, okay, we all know we're going to have to remake this lower denture. And this lower denture is going to have to be at least 7mm shorter than it is right now. 7mm is a long way. 7mm is the length of a lower incisor. Okay, so we're going to have to make this considerably shorter. But just to complete the lesson, I want to know how thick the denture base is. Now, the general dentist or prosthodontist will say, well, fine, you get a caliper and you put it between it. Well, I use a periodontal probe. So I'm going to show you how we use a periodontal probe, because I have plenty of probes in my office, and a caliper we have to go looking for. And I'm at the chair, so I'm going to use the probe. Okay, so I'm going to put the probe in, and I'm going to put it into the depth where the probe is feeling the ridge area. Okay, so we're putting the probe in as far as it'll go. Okay, and we've measured that at 7mm. Okay, subtraction exercise I'm about to show you. All right, so now I duplicate the 7mm on the outside. So this is where the denture base is. Now I'm taking that probe, and rather than being the inside, I know it's 7mm, so that's where it is on the outside. I make a little reference mark. Now I'll do it in my head, okay, because I kind of know where I was. Okay, so I have a mental reference mark. Okay, now I'll measure from the top, and sorry for being angled, it shouldn't have been, but now I know it's 11mm from the incisal edge to that reference point. Then I'll place the probe behind the canine tooth to see how long the canine tooth is before I reach acrylic. And that's 3mm. So if I subtract 11mm minus 3mm, it means the denture thickness is 8mm. Okay, so there's that's where the probe is, just to kind of give you an idea how far the probe is. And so that's the 3mm. I subtract that from my 11mm length, and I've got 8mm. Okay. Now, how much thickness do you need to house a locator? Remember, she wants snaps. Anybody know? Okay, it's 6mm. The snap, the housing, is 4.5mm. And so the rule is a 4.5mm housing, you need 1.5 millimeters of acrylic around it. Therefore, you need a 6mm thick denture base. Okay, this is an 8mm thick denture base. This denture base is certainly thick enough. If this denture were okay, this denture base is certainly thick enough to house a locator attachment. Well, let's take a look at this patient, and we'll take a look at the mandible again. Now, remember, we talked about that mandible being pretty thick. And now we know that the patient is open by at least 7mm and perhaps 9mm. What do you know? If you put implants in this condition, if you put implants even with a crest of the ridge on the lower, what would happen? You essentially have to have a denture made that opens her vertical dimension. Oh yeah, you could make the teeth a little bit shorter. Could you make them 7 millimeters shorter? No. And remember, the denture base is only 8 millimeters, and she's open at least 7 millimeters and perhaps 9 millimeters. So what do you know? You're going to do an alveolectomy, right? And so we have to do an alveolectomy there. I just drew in, it says 7.51. I couldn't get the 7 exact, but that's the idea. You're going to do a 7 millimeter alveolectomy at least, and probably a 9 millimeter alveolectomy as you're planning the case. I just drew this out for the 7 millimeters. 7 millimeters is the constant, but we got to add the free weight space to it. So it's at least 9 millimeters of an alveolectomy that we would do before we put the implants in place. Okay. And that's essentially how we take care of a patient who has this kind of a problem. Now, yeah, she's went a little bit faster than I thought. Okay. So what do we learn from this? A patient that comes into the office who's frustrated, we need to find answers to the frustration. If we find answers to the frustration, duplicating her speaking sounds, duplicating her chief complaint, tightening up the upper denture, then showing her exactly what we showed her. We talk about why we're doing the dot in the nose and the dot in the chin. And I'm showing her that she's open at least 7 millimeters farther than she should, and that's why her dentures are clacking together. And that's why she can't speak. All of a sudden, bells ring, lights light up, patient's happy, saying, oh, I think I can get help. And he's the one who can help me. Now, she hasn't accepted treatment yet. Now, I've got to be totally straightforward with you. We have a consult with her again next Thursday. What do you think she told Laura? She said, I'm going to try to do both the lower implants and the upper implants and do them as a fixed prosthesis. Not locators. I'm going to see how I can make this work. So when she comes back next Thursday and we have the consultation with her, she may change her mind. She may talk to her husband. You know, her husband is obviously concerned, and he's also concerned about the money. And he wasn't there on that day. I wish he was in the office on the day, because for him to observe what we were doing is better than her reporting back to her husband what we did. I'd much rather have the spouse or a trusted member of the family in the operatory, because I want that person to see this, and I want them to understand what exactly was being done, because it loses something in the translation. So if she chooses locators, fine, we'll do locators, and we'll reline the upper denture. We'll reline the upper denture. It has good suction, and she might say, as many of us say, we'll take care of the lower now, do lower fixed now, and later on I'll do the upper fixed. And we know she has plenty of bone for that. Okay, so think of all the diagnostic things that you can do. We've taught diagnosis here. Take a look at the old videos. Every time you get a registration form now, or when you fill out the registration form, if you just scroll down, you'll see almost all of, there was one I made an error recording, but almost all of the treatment planning sessions that we've done since last October. And you get an idea as to what the exam sequence is and how we do that. And we go over exam sequence in these programs every single week. The exam sequence essentially allows us to have a checklist, so that we're going all the way through. Now, was this on the checklist? No, it wasn't. But we want to go step by step by step by step by step. Looking at Mallampati's score. Looking at pocket depth, maybe recession, mobility. I mean, you know, you're also looking at angles class. You're checking your TM joints. I think there's something like 24 different items that we check as we're going through. It doesn't take very long. Maximum opening with a TMD wedge we got from Henry Schein. Okay, how far can they open? But the more things you're doing, the more opportunities the patients are having to say, "Oh, I've never had this done before at any other office." And for me, I've got information that I wouldn't have gotten otherwise. Who do we do a full examination on? Everyone. Everyone. There's no such thing as a patient coming in for a limited examination. Doesn't occur. Doesn't occur in our office. Okay. And the only way I can provide the reason I do that is I don't have all the information. And I'm certainly not going to depend upon the referral source to do the full diagnosis for me. That's my job. Then we might do what's recommended by the referral source. That's fine. It's within your purview. I think it's the right thing to do. By all means, do it. But certainly, be the specialist that you should be, or generalist that you should be, and do the full examination, and glean the data. Let the patient understand that you're the right person to go to. Okay. Are there any questions? I see one question. How long this examination take me? This one, Jessica, took me, I bet you I was there for 45 minutes. It wasn't a full hour, I know that. But about 45 minutes as I was playing with the wax and that type of thing. Yeah, yeah. Could I have done it faster? Yeah, I actually had the extra time. You know, there's an advantage here for me, and it isn't the same answer for you. So the answer for me is, because I only do examinations now. I don't do any treatment anymore. I haven't done treatment in several years. That there is that half-hour block for me, and then there's another 20 or 30 minutes before I'm seeing the next patient, simply because we've got 3 doctors and we're juggling chairs, and you know, it's a jigsaw puzzle putting our schedule together. And we teach scheduling, as you know. And Jessica, you know about scheduling very well, because you've gone through the entire library. You know what we're talking about with scheduling. So it does give me a little bit of an opportunity to take advantage of that. Listen, it's the only thing I do besides talk to you. So I like doing it. Can you get it done faster? Sure. And I would make it a point to try to get all of your data points done in 30 minutes. So just because I took a little bit longer doesn't mean that you have to. And you know, you've got the rope wax right there. There's certain things that you can do to speed this along. Are there any other questions? Yeah. All right, good. Not a question. Oh, thank you, Dan. That's so nice. Dan, I hope your residents are coming on, or if they are, or if they're not, just let me know that if I'm providing material that they can use. So I appreciate your referring them over here. All right, good. We'll do another one next week. I don't know if I'm going to do the other failure case, or the other nightmare, or a nightmare that we're avoiding. I don't know if I'll do it next week or not. It depends upon the patients that come in next week. I had 4 great patients that came in this week, and I could only do 1. That's a shame. But depending on what we see next week, or I may take one of this week's patients and provide it next week. So I hope that you're getting something out of this. And if you are, please refer as many people as you possibly can to join us. Okay. Thanks for joining us. I'll see you again next week.